CataractCoach.com. Trocar placement punctures the lens. Fortunately, this patient's already scheduled for combination cataract with vitrectomy for a macular hole. Now let's watch the case here. And we've got trocar being placed here. It was the first trocar, and you're obviously using the marking system, so you know exactly how far behind the limits you're going to go. And then there's trocar number 2 is in. Now trocar number 3, watch carefully. Trocar number 3 goes in appropriately. A little bit of resistance trying to get it in there, and you finally get it in, and look. Ooh, what do you notice? Looks like it hit the capsule. Now the trocar tip doesn't appear to still be in there. I think it's just nicked the back of the lens capsule there. So what's going to happen? That's definitely going to split open when you try to do the surgery. So now the surgeon's making the incision for the anterior part of the eye. Here comes the capsulorhexis. So good news here is you're going to have to do the combination surgery. You definitely get the cataract out, but you definitely need a great rhexis. So at this point, hopefully you're going to put on a monofocal lens here, and you can get a 3-piece lens beautifully placed. So you really want a good, beautiful 5mm rhexis, just like that. That's a great looking rhexis. So that 5mm rhexis, you're going to be able to do an optic capture. So here's some hydrodelineation, gentle on the hydrodissection, because otherwise the whole nucleus can fall back. Obviously, you can still do the pars plano lensectomy. You can get it out if you do drop the nucleus into the vitreous cavity. But it's kind of helpful to get it out through the front of the eye. And so a little bit of hydrodelineation is good. I wouldn't do too much hydrodissection, and I'd remove it kind of in its place where it's at. I wouldn't necessarily do any rotation, etc. I know I always tell you, if it does not spin, you're not going to win. But in this case, I don't want to spin it, because the more you loosen it up from that capsule attachment, the higher risk of dropping it back there's going to be. So here, I'd actually be tempted. It's not a very dense lens. I'd be tempted to get the whole lens up and bring it into the anterior chamber. So maybe bring it up iris plane level. But here you're just doing a single kind of bowling out technique here. Works pretty darn well. Get that all bowled out. Looks great. And be careful. And again, if anything does fall back, you can take care of it with the pars plano lensectomy, with the posterior approach. But in this case, it's kind of helpful to get everything out through the anterior approach. You could examine the eye afterwards, and maybe the capsule's not split open. Maybe you just have a focal defect, in which case maybe you could still put the lens in the bag. But let's find out. But just remember, one little break in the posterior capsule tends to rip. It's kind of like a run in stockings, right? You get a little hole in the one stocking, and next thing you know, it's running, and you got a huge rip. So again, here, trying to do some hydrodissection or maybe viscodissection, get that lens epinuclear shell up. Yeah, that looks like viscoelastic. Good idea with the viscoelastic. I like that. Very smart idea. And now just aspirate this thing down. Good. Keeping it in one piece. Don't break it up in small pieces, because you may get those pieces floating around everywhere in the back. And so here we go. Wouldn't have come out without putting viscoelastic, but okay. And maybe let's take a look. Do we get lucky to have a totally intact bag? Because you definitely saw some marks on it. No, I can't be. I just can't believe that. Let's see. It's taking it out. Okay, take out that cortex. Let's look back there. And there's probably going to be at least some sort of little defect, right? Just think about it. Because you saw those marks that were pretty clear. So I'd still be cautious. And the better part of judgment for me, to be on the more cautious side, is still putting a 3-piece lens, haptics in the sulcus, optic captured behind the rhexis. I think that's probably going to be your best bet. And let's take a look here. What else we got? And it looks to be, okay, getting that cortex out. It looks like the capsule's open. To me, it looks open. Going from, in your view, from about, let's say, 10 o'clock to 4 o'clock position, there's a big rip, a diagonal rip there. Yeah, it's open for sure. There it is. Yeah, so capsule's already open. Beautiful cleanup here. I don't even know if you have any vitreous prolapse. You may just get super lucky here. And so now, let's see what we got. Are you going to put some, was that viscoelastic going in? Yeah, the capsule's really wide open now. Yeah, I'd like the sulcus placement, that's for sure. That's for sure. Now, you could just do the full vitrectomy right now. You could save the lens till the end. Here's probably a neat idea. You don't have to put the lens in right now, right? You can certainly run a surgeons all the time. You can operate through an aphakic eye. So you can operate right like it is now and do the full vitrectomy first, and then put the lens in later. But let's see what we got here. You got putting a lens in. Yo, single piece. Okay, you were more brave than I am. You were braver than me for sure. I guess you're going to rotate it 9 degrees away from the break then? So in your view, maybe like 2 o'clock to 7 o'clock position, you're going to rotate this lens? Or 2 o'clock to 8 o'clock? So yeah, I wouldn't want the haptics right there. I'd want that to rotate. Yeah, I rotate it more. Oof. I don't know if I love this. Because aren't you going to put an air bubble in the eye? If it's a Mac hole, right? Aren't you going to do a full-on vitrectomy? Then you're going to put the air bubble and face down and all that nonsense? I just think it'd be a lot more stable with a 3-piece haptics in the sulcus and optic capture. But let's see what we get here. And again, the other option is just do the full vitrectomy first. And you've already got the trocars in, so I'm sure you're going to do the full vitrectomy right now. And it looks pretty stable. I'll give you that. It looks stable. Leave a comment below. What would you do here? Am I just being too conservative? You know, that happens sometimes when you get old. Maybe the young guns will teach me a lesson. Make a comment below. Let me know what you think. And remember, check out our sister channel, RetinalReynolds.com.